Joining us now is Dr. Roger D. Klein, and he's a clinical pathologist with specialty training in medical microbiology. He's certified by the board in molecular diagnostics. That's molecular genetic pathology. I bet you didn't even know what that was. He also directs the type of clinical laboratories that would make the diagnosis of coronavirus. While a pathology resident at Yale in 2003, this guy's really smart, he saw the first suspected SARS case in Connecticut. Now, and he is joining us now. Dr. Klein, great to have you with us.
Hi, John. Thank you for having me.
You're also uniquely qualified to discuss both medical and policy impact of COVID-19 and how it could affect the U.S. For instance, what do you think of President Trump's instincts? Is he on target, saying that he would love to have the country opened up by Easter? You get a lot of medical people say, no, we have to shut this down till August. Of course, if we do that, there's no country. So there's a balance, doctor. What did you think of that? Did the president do the right or the wrong thing in setting that goal, sir?
So I think he did the right thing. I fully support it. You don't want to cure the disease and kill the patient. I think his instincts are good. Look, the truth is, if we really look at the numbers, and I've been following them closely since the beginning, this is very bad. I mean, every death is terrible, but the relative to other diseases, the numbers are still relatively small. I mean, if we lose 60,000 people a year to the flu, we're talking right now about 1,300 deaths in the United States. So we've got a ways to go, and we don't typically shut down the country for infectious diseases. This seems a bit more severe. It seems to spread relatively easily, especially in high-density populations like New York. But I think we need to start, as we get more information, which we're doing, we need to start moving back toward normal.
When you say get more information, Doctor, I ask this to every person who comes on. I'm yet to get an answer. I want a metric. When everybody says, well, we need to bend the curve, and these governors are shutting states down, and they're now having neighbors rat out other neighbors if they walk their dog too many times, putting other residents at risk by walking a dog or something. Bend the curve. Give me a metric. What does that mean? What does that look like? Give me a number.
Yeah, that's a great question. Because to me, this bend the curve is a very, it's kind of a nice catchphrase, but it has relatively little meaning, which is why you get relatively little answers. What we're seeing is the combination of increased testing and increased spread, and we really don't know how to distinguish those. We're not able to distinguish what are truly new cases right now from what is a result of increased testing, and we knew we'd see an explosion in cases when we had an explosion in tests. We're doing 100,000 tests a day now, so of course we're going to pick up more cases. What's the surprise here is how broadly it's been circulating. I think that's really the surprise. That's a bad sign in the one sense that that there's a lot of spread, but it's good in the other because it really means that it's, for most people, this is going to be a mild disease. It's infrequently severe and rarely fatal.
Right, so it's got to circle through society. Many of us have it, asymptomatic, don't know that we have it. It seems like, Doctor, comment on this, it seems Dr. Fauci said yesterday, he said it seems that if you get this virus one time, you get immunities built up and you don't get it again. True or false?
Well, we don't fully know, but it looks as if it doesn't mutate a lot, doesn't change a lot, and that suggests that the way you get immune is you have the disease and you build up what are called antibodies against antigens, which are proteins that the virus puts on outside of your cells and that it takes over. And what happens is you have those antibodies and they stay with you. And if the virus doesn't change its genetic component substantially, those presumably don't change much, and you could have lasting immunity. We do that with some viruses. We do. Flu is unusual in the sense that it changes quite a bit, and every year you get a different strain, and so the flu shot may or may not work, depending on the type of strains that predominate.
We're with Dr. Roger D. Klein. Dr. Klein is a clinical pathologist. He has a subspecialty training in medical microbiology, and he's also certified in molecular diagnostics, which is molecular genetic pathology. And while a pathology resident at Yale in 2003, he saw the first suspected SARS case in Connecticut. So, Dr. Klein, we understand that the number of people infected are going to continue to go up as we do hundreds of thousands of tests now a day. In New York, you've got positivity rates of 50%. What does that suggest? Could the country be at 50%? And if so, what's going to be the mortality rate that you predict?
So the rate of people having the disease is not 50%. The rate of testing at some institutions of friends of mine to whom I've spoken and are running those labs is 40 to 50%. But these are pre-selected patients because they're coming in. First, they're mostly coming to the hospital. So you have by that they're selected by symptomatology, and then secondly they're tested for other things first. So that what it suggests is not that 50% of the people have the disease. It may well be the case. What it suggests is there are very large numbers of people who are infected and probably don't experience significant enough symptoms to seek medical attention. We don't know that for sure, but it's just that based on those types of rates, when in other places like Washington State we're seeing 7 to 8%, you just have to make the assumption that this is very, very has spread very widely in New York. And yeah, I mean, if what I would say is if it's that diffuse and that broadly spread, and no country in the world, by the way, has anything approaching that. There's not even 1%. But if let's say it's true, then it's going to turn out to be a not all that fatal disease. I mean, it's going to be more like a flu type disease than what we initially feared.
So if you get the common flu, the mortality rate is 0.1% of 1%, right? Everybody now knows what that figure is. 3 months ago, no one had any idea that 70,000, 80,000 people died annually from just the flu. The mortality rate's about 0.1%. Some doctors and medical people looking at the percentages now are saying that when this is all said and done, the coronavirus it's going to be under 1% mortality, maybe 0.5%. So that would be 5x the flu, maybe 0.7%, 7x the flu. Still a big number, but nothing like the 3 to 5% that was being predicted earlier.
No, and I don't think we know fully yet. I mean, one extremely good epidemiologist gave a range of 0.05% to 1%. And so,
right.
So I don't think we really, what we don't know is when we figure out these equations, we don't know there's a numerator and a denominator, the top and the bottom. We don't know the bottom number. We don't know how many people are walking around with infections. And we're going to find that out because there are tests called serology tests. They're antibody tests. The same, they test for the defenses that I spoke about earlier, those defense proteins. They can tell whether the infection, they can tell whether you've been infected and whether it's present, it's acute, it's a near term, or whether it was later and you've resolved. And once we have better population data on that, we'll have a very good handle on how extensive it spreads and therefore what hospitalization rates and death rates are. But it does depend on the population. And even flu. For example, H1N1 was very severe in younger people. This seems to be worse in older people in terms of the severe complications or the sick. And that 0.1%, it could be 0.15%. These are all estimates that depend upon the season and the people who it's affecting.
Have we overreacted?
We'll find that out. I've all along been somewhat concerned about the panic. I say in that from that standpoint, yes. I don't think there's any question. Did we need to shut down the country? There's going to be a lot of finger pointing, and what's going to happen after this resolves, and we will have control, but I'm not saying it's going away. We will have control. We will manage it like we've managed every other disease, worse ones like HIV. We will manage this very soon. The president's right. there'll be finger pointing, and people who implemented these measures and advocated for these very extreme measures will say, we saved you and we saved us, and people who were opposed to them will say this was just a big mistake.
If this does ebb, and I think it is too, both sides are going to claim victory, right? Those that shut everything down are going to say it ebbed because of us, and then the people that are more on my side that think there was a lot of hysteria that went into this, they're going to say, well, this is just something, like I've been saying for 2 weeks now, this is something we're going to have to live with, right? For a while, you're just going to have to live with it. I'm just not for shutting the government down or shutting business down and destroying the country and having no jobs available, like the president said, where the cure becomes worse than the disease. And then, of course, what you have, doctor, this is not a medical issue, but you got the politics of this, where a lot of people try to take advantage of the crisis in order to get their pet government projects done. That's highly annoying, but not really your area of expertise. This is the John Fredericks Radio Network. We are with Dr. Roger D. Klein. He's a clinical pathologist from Yale. He was also, he saw the first suspected SARS case in Connecticut in 23, and he's also certified in molecular diagnostics, that is molecular genetic pathology. This is a really smart guy we've got on. When we look at the mortality rate at something under 1%, one of the fears that we're being told, and the reason why we have to have these lockdowns, is that hospitals could get overrun, the health system could totally collapse. What is your take on that, sir?
Well, I don't think that's going to happen. I think that we're seeing some problems in New York, but you have situations with certificate of need laws and other restrictions. They've cut back on beds. So part of this is self-induced. I mean, if you limit the number of facilities, then you leave yourself ill-prepared. I think there's a lot of capacity in the United States. One of the things that we need to be able to do is shift things around maybe a little better, and that's that. I mean, we have all these ventilators sitting there, for example, in surgery that we're not doing surgeries now, and they can be converted to be used. They can just take them up to the ICU, but if you're strained in an area, there are surrounding areas that don't have the same level of infection, and as manufacturers ramp up, we can share. We need to have some better vehicles for doing that, because I think there are some areas, especially New York. I mean, New York is, but I think it's pretty unique. I think it is unique in this country. People living in such so many people living in such a dense area where they're obviously predisposed to spreading anything, and then the resources are constrained. I think that they have more problems probably than other areas are going to have, and it does seem to be they have a very extensive network of public hospitals that seem to be under-resourced, and that's also part of the problem.
It's interesting that you bring that up, because there seems to be that we need a reallocation of some of these respirators. You get a lot of them in areas where you just don't have the need, but hospitals don't want to give them up in case they have the need. So, again, overreaction and people not necessarily doing the right thing for resource allocation. We're with Dr. Roger Klein. Doctor, final question. We're running short on time. Vaccine or treating the symptoms, the malaria drug, sir, what do you see there?
Well, I think that, I think it has potential. We don't have proof that it works. On the other hand, it's, the safety profile is well understood, and I think in the right patients, any doctor can prescribe that. They could have at any time. It's an approved drug, and I think, with the right conversation, the right patient, it certainly makes sense to try it if you don't have anything else. There's a number of other drugs under study, and I think the antiviral drugs actually have a lot of potential, and there's opportunity to get those early access as well. And in the right patients, certainly you want to try things. You're always balancing benefits and risks, and it's a joint decision with a doctor. But if you don't have a lot of options and you might die, and things present very little risk, it doesn't seem it seems prudent to try it. I mean, I'm kind of in that mode. It's kind of an easy decision, in for example, with hydroxyquinoline, where you're, chloroquine, where you're where you have a relatively safe drug, and if you're dying, you are extremely sick, the risks versus the benefits definitely seem to favor the potential benefits, even if we know it doesn't. Even if we don't have proof it's going to work.
Dr. Klein, the president says, "Look, I want to get things reopened by Easter." What do you think of that?
Well, an exact date is. I think he's right to have a goal. Look, I mean, this is what I like about this president. Having a business guy in there instead of an entrepreneur, instead of a bureaucrat. You have somebody who's trying to move the country forward. He's pushing, and people give him. He's criticized for this and saying, well, he's not listening to the scientists. But I say no. I mean, I think it's the opposite. I think what he's doing is he's trying to get people to think ahead, to try to motivate people to stretch beyond what they might otherwise do. I think he's right. We need to get control of this. We need to get parts of the country that are less well affected, particularly, up and running again. And I think we can do that if. It's really a question, again, of managing this. It's a question of understanding it well enough to manage it, focusing on the people at highest risk, getting sick people away from other people, these kinds of practical measures, hygiene, that can get us back to a regular life. We have 1,300 deaths here right now. That we have thousands from the flu every year.
There has been such a wide debate now over how many people die from the flu. The president a month ago came out and said it was about 70,000. Other people have said, well, it's like 1,000. How many people in America a year without coronavirus, sir, on average, die from the flu?
Well, I use this number of 60,000, which is a little bit toward the higher end. I mean, toward the somewhere in the range, the mid range. For this year, recently was about 30,000. What I would say is, what happens is these are not real measures. We don't actually measure who dies. We don't follow every death the way we do with coronavirus. We just estimate it statistically, and as a result, you have a very wide range.
Right. Thank you.
So it might be like 25,000 to 85,000 or something. We really don't know the actual answer. The president's number is within ranges that I have seen from CDC. I think 60,000 is what is the number, is a little less than they were saying may have been in 2017, 2018. But again, these numbers they're estimates, and they have very wide confidence intervals, and you can what are called confidence intervals, meaning the range. And
right.
It falls probably somewhere within this very broad range, but it's thousands, definitely thousands. It's not 1,000.
Doctor, we're out of time. I want to thank you for being with us today. Dr. Roger Klein, you can follow him on Twitter at Roger D. Klein, clinical pathologist and subspecialty training in medical microbiology and molecular diagnostics. Every time I say this, it's like, wow. Also, he does molecular genetic pathology, Yale graduate, and saw the first suspected SARS case in Connecticut while a resident at Yale. Dr. Klein, thank you for being with us, sir.
Thank you. Thank you for having me. Appreciate it.
Thank you, Dr. Klein.